Ladies and gentlemen, welcome to the EpiMed webinar. I am pleased to present Dr. Stefan Willich. For the first part of this call, let me remind you that all participants will remain in listen-only mode, and there will be a question and answer session at the end of the presentation. Dr. Willich, please begin.
Thank you very much for the introduction. Ladies and gentlemen, dear colleagues, welcome to this webinar from Berlin, Germany. I started my medical work well over 30 years ago, actually in the field of oncology, doing some research in metastatic breast cancer, looking at therapeutic options. And already then I found it rather frustrating to work in oncology because therapeutic progress had been seen only very little, if at all. And so I ended up focusing much more on other fields of internal medicine and cardiology than in my clinical work. However, following several decades of frustration, since a few years ago, there's clearly a very new trend, almost a paradigmatic shift in oncology, associated with a lot of enthusiasm on part of clinicians and, of course, also hope for patients. And that is due to personalized medicine, to the development of personalized medicine, and that is the overall topic for today. Let me start with the slides that you should have in front of you. It's called a preview because what I will present to you is the basis for a study that we will publish and present in 1 week from now, October 28 and 29, at the EpiMed Annual International Conference, which takes place in Luxembourg. So this is a preview on personalized medicine in Europe, enhancing patient access to drug diagnostic companion products. Let me just give you a brief overview where I'm from. I'm head of the Institute for Social Medicine, Epidemiology and Health Economics of the Charité University Medical Center. That is one of the largest European medical facilities, including a bit over 100 departments and institutes. Now, our own institute has about 50 co-workers, and we focus on 4 main research areas. First is health economics and outcomes research, and that is also the area, of course, that this project has been conducted. The second area is clinical epidemiology. We do large-scale trials, epidemiology trials, or observational trials, or also intervention studies. Then we have a third research area, which is an international unit focusing on global health. And the fourth one of our research areas is dealing with complementary medicine, that is the interaction of conventional medicine and alternative medicine, for example, acupuncture for chronic pain syndromes. Our institution is quality certified with respect to research and teaching, and we work, of course, with a lot of grant supported research in the range of about 1 million euros per year. Our publication record is depicted on the right panel. In 1995, I came to the Charité. Before that, I worked in the United States. And then we built up together this institute. And as you can see, we have a substantial publication record and impact record. Now, let's focus on today's topic. What is personalized medicine? Personalized medicine can be defined as a medical model using molecular profiling technologies for tailoring the right therapeutic strategy for the right person at the right time and determine the predisposition to disease at the population level and to deliver timely and stratified prevention. Of course, there's other definitions around there. The term personalized medicine has been debated for a long time, but I think this is clearly pretty much of a gold standard. Now, molecular profiling includes several different potential stages. It could look or help in assessing, in terms of predisposition, the risk of developing a disease. And of course, a classical example now is the BRCA1 profiling for breast cancer. Molecular profiling can also be the basis for diagnostic testing to identify a specific disease. For example, hepatitis C virus RNA following an infection. Molecular profiling can also be the basis for prognostic assessment, predicting the course of disease, for example, by using oncotype diagnostics for breast cancer. Molecular profiling can be used for monitoring, keeping track of the disease progression, for example, in the treatment response for leukemia treatment. Or it can be predictive, to predict the response or reactions to a therapeutic drug, for example, the BRAF V600 genetic alteration in melanoma tissue. Companion diagnostics as a concept includes tests for predictive biomarkers, drug use, obviously depending on prior testing. There's different levels of codependency defined in the drug label and usually required or at least recommended. And essentially, companion diagnostics means the inseparable combination of companion diagnostics and treatment. Now, to give you an overview of the number of substances we are currently talking about in the European Union are a total of 34 substances associated with companion diagnostics approved for use. 26 out of those 34 require a test, and for the other 8 out of 34, the test is recommended. Now, most of them, and that's what I considered initially as the breakthrough area, is in oncology. I think there is truly substantial optimism and enthusiasm about this new therapeutic strategy. And in the oncology area, we're talking about 26 approved substances. 23 out of those 26 require testing, and in the other 3, test is recommended. There's some other therapeutic areas with a total of 8 approved substances, and 3 of those require testing, and 5 have at least test recommended. Well, let's give you some examples for the companion diagnostics and drug combinations in oncology. First is for melanoma, using BRAF V600 mutation as the biomarker, and then treating with vemurafenib. The other is breast cancer, using HER2 overexpression as biomarker, and then treating with trastuzumab. And the third therapeutic area that I would like to give as an example is non-small cell lung cancer, where the epidermal growth factor receptor tyrosine kinase mutation is used as the biomarker, and followed by treatment with alutinib and gefitinib. Now, the reason that oncology is such an important area for personalized medicine, cancer, of course, is one of the leading causes of death worldwide, still accounting for between 20 and 25% of all deaths, depending on the different society and the relative importance of other diseases. But 20 to 25% of all people, overall mortality is due to cancer. Tissue samples in cancer are usually available for testing in biobanks. Molecular pathogenesis of disease is relatively well understood compared to other disorders. And of course, last but not least, cancer is mostly or often a serious life-threatening disease, and patients are ready to accept risks associated with invasive diagnostics. Now, companion diagnostics and drug treatment in oncology promises better health outcomes because the drugs can target molecules that are directly involved in the pathogenesis of disease. There have been numerous studies performed investigating the effects on health outcomes. In oncology, of course, the response rate is important, then the progression-free survival, and several studies also have looked at overall survival. Now, the challenge, of course, is huge potential heterogeneity. But the primary site and metastases can be different already. Then even within one tumor site, heterogeneity may be found in the tissue. And finally, of course, the tissue can change over time, tissue characteristics, so there is a third element of heterogeneity. Potential benefits and risks of companion diagnostics include, on the benefit side, we obviously hope for increased effectiveness or less side effects. We hope, given the budget constraints in many healthcare systems, for a more efficient cost allocation, and of course also on the industry side for more efficient drug development. The risks of companion diagnostics include in particular suboptimal selection of population, so that not the right group of people or the right subpopulation is treated adequately. There are several trends to be observed, current trends in the area of personalized medicine. The trend from single to several tests for the same biomarker drug combination, or also a single biomarker to be used instead of several testing. Then testing panels are under development, that we have a single test for covering several biomarkers. Whole genome sequencing is clearly another current trend. And then beyond the molecular genetic level, there is the epigenetics, transcriptomics, proteomics, metabolomics, so all these other factors that may well be used for diagnostic testing. In vitro diagnostics directive is under revision and presumably applies between 2015 and 2019. The new classification of in vitro diagnostics is according to risk from self-certification or to notified bodies evaluating a clinical evidence report. Laboratories developing in-house tests required to be compliant with accreditation standard, ISO norm standard, or any other equivalent recognized standard. There's obviously a big interest in having standardized quality control established. The objective of our research project, which will result in a white paper on personalized medicine in Europe and enhancing patients' access to drug diagnostics companion products. The objective is to analyze patient access pathways to drug diagnostic companion products, focusing on the big 5 markets in the European Union and focusing on a patient's perspective. We seek to identify factors impeding patient access. We seek to identify factors facilitating patient access and to develop policy recommendations on the basis of these identified factors. The methodological approach we chose was first to review current relevant publications based on peer-reviewed literature, based also on industry and company reports and presentations. So in other words, it's published literature, but it's furthermore industry and company reports. Secondly, we conducted exploratory interviews with expert stakeholders, approximately 30 interviews with clinicians, with scientists, with healthcare managers and healthcare politicians. And then thirdly, we described for drug companion diagnostics, codependent therapeutics, the post-approval patient access pathway country by country in the European Union 5 markets, the 5 major markets. Now keep in mind that the patient-provider-payer interaction is quite complex and of course very relevant given this potentially very costly area of personalized medicine. So on the one hand, on the left side, we have the patient-clinician interaction or patient-hospital and pharmacy-hospital interaction, whereas patient usually, of course, has to pay the premium to the payer that then reimburses the pharmacy and hospital or the clinician. And of course, the pathologist and laboratory also plays a major role here in terms of interaction with the clinician, but usually not with the patient directly. In our study, we focused on 4 different levels. In other words, we had a framework looking at patient access from an approval perspective, then health technology assessment perspective, which of course is always a crucial issue for many of the national agencies to accept new therapeutic or diagnostic approaches in usual care. Then the pricing and reimbursement or funding perspective, and finally the healthcare provider's perspective. Now the questions the study seeks to answer is, how does patient access in the EU5 markets actually work? What are the key barriers to access? What should be done to improve patient access, and how should systems prepare for the future environment? So I hope I have made you curious enough to join the Luxembourg conference, or at least keep your ears and eyes open for the results. I would like to acknowledge the work of the co-authors, particularly Dr. Markus Bücheler, who did most of the work at our institution, and also Dr. Bernd Brüggenjürgen, and many other people that participated in the study. Thank you for your attention, and I look forward to your questions.
Okay, ladies and gentlemen, we will now begin the Q&A session. If you wish to ask a question, please press the code 01 on your telephone keypad, and you will enter a queue. And when you are announced, you can ask your question. So once again, please dial 01 on your telephone keypad now. Thank you. Okay, no questions are coming through as yet. It's still possible to ask a question by dialing the code 0 and then 1 on your telephone keypad. Thanks. It seems that no questions are coming through. Dr. Willich, should I hand back to you?
Yeah, I think then everything seemed to be clear. I, again, would like to invite you to join the EPIMED Annual International Conference, which will focus on health economics and personalized medicine this year, the coming Monday and Tuesday in Luxembourg. I think it will be an exciting conference, partnering with European Commission for Health and Consumers, Luxembourg Ministry of Health, among others. And I think we will have opportunity there to then, of course, present the results, and we'll also distribute that and publish that, so that you will see the results of the study that I presented. Thank you very much.
Sorry, just to interrupt, we do have one question which has come in on the WebEx, actually, from Ian Miller from Healthcare Strategies Group. And he writes, are EU markets ready to accept and reward high-value diagnostic tests?
Well, in a way, I think that's a crucial and critical question, of course, because the question, what means value, what means high value, is, of course, fiercely debated in different societies and different markets. I think in general, if you can demonstrate value or even high value, if you can demonstrate that a therapeutic strategy actually works, is effective, and is also from a cost-benefit perspective acceptable, then the majority of markets will clearly, in the European Union, will clearly accept that. And but of course, looking at the details of different healthcare systems, there's big variety in terms of procedure, and I guess one of the underlying goals or underlying objectives of our study was that we aid or support general European procedures, how to develop that field adequately, and how to foster implementation of personalized medicine in a way that it benefits patients and, of course, also clinicians and healthcare in different healthcare systems alike.
Okay, otherwise, no further questions have come through right now.
Okay.
I just did a final check, but no questions have come through. So shall I hand back to you, Dr. Willich? You can...
Sure.
You managed to close again?
Sure. Okay, once again, thank you very much for your interest and attention. And I hope to share the results of this new study with you in the near future. Thank you very much. Goodbye.
Ladies and gentlemen, this concludes today's conference call. Thank you all for attending.